Good afternoon to all of you. I am Dr. in charge of the academic activities and convener. It is my respectful duty to present you about the last year activities, not by slides but by example. And then the end of the year, December, we analyzed all the presentations of our residents, both postgraduate residents and specialty senior residents, and the faculty presentations. And we have formulated in the last 1.5 decades itself, almost 1 decade back, to give prizes in various categories of our academic activity, that is continuous quality improvement program and interesting cases presentation, as well as number of cases and discussion, as well as investigative departments and the participation. Unfortunately, the list is ready long back in the January itself for certain reasons of examination and other things. It was postponed today. Before we go into this academic component, I shared some of my observations of my association with various regional institutes for the last 1.5 decades and of late 1 year. Newer and current information. We have got a good amount of Wednesday academic activity in 4 sessions, 4 Wednesdays. That is continuous quality improvement of reviewing the mortality cases of previous month with the involvement of all the postgraduates of the respective departments, which is a good augury established, and 2 CPCs of every department, the timetable being circulated 1 year ahead without any interruptions. 3 interesting cases subscribed and presented by various departments. 4 guest lectures. I have to make a submission first that this robust academic activity is sown the seeds by our Director General with a lot of enthusiasm as well as foresight and vision. In 2012, at the time I am not joined here. Why I know you may ask me. I was called upon to discuss a medical case. I still remember that case. That is a rare case of autoimmune hepatitis type 2. And then at the time, there is no institute in Andhra Pradesh to conducting the clinical pathological conferences. From that onwards till now, almost 14.5 years, 12 a month, almost 174 clinical pathological conferences are conducted in this college. None other than any college has made even digital figures, double digital figures. Now, 75% almost we have got 16 colleges, out of which 5 are old government and another 5 are new government college of undergraduate and 5 are private sector senior colleges, another 5 are junior sector colleges. Almost 50% of the senior colleges, which I verified of late in this 2026, there is no college which conducts clinical pathological conferences. And they may conduct only a few cases of interesting cases, not like a regular conference, once in 2 months or other way around. While saying this is, I am responsible for initiation of the case presentations in 1987 in Siddhartha Medical College with a meager staff of 2 individuals. One is a chest physician, Bhan Prabhakar. The other one is neurosurgeon Rangarao with his teammates of 3 surgeons who are all now renowned neurosurgeons and outside practice. Vajra Sivakumar and Srinivas Reddy, neurologist, and another Srinivas Reddy of neurosurgeon. We used to have only 45 minutes to 60 minutes of discussion of 3 or 4 X-rays and cases. That's all. That we initiated continued for a good length of time to the extent of making clinical presentations until 2010 and beyond 2 years after my retirement of 200 and odd cases. Later I do not know the pursuit. But when I pursued in 2026, it is becoming a very slender, like a malignant, ravaged, pathetic individual in presentation in various parts. And I was proud to have an associate with NRI and thought that it was a great amount of academic activity going on. And recently I gone there and they called me for one discussion. To my surprise, I am not saying that our seat, because I am conducting it is at a higher parlance, but because I have seen both and assessed it independently without any bias and other things. They conduct once in 3 weeks or once in a month, all mixed together. Nothing more than that. There is nothing like a continuing discipline of conducting every once a day. Nowhere. That is, then what is the utility of this? Nowadays participating, it is becoming a dead exercise. A teacher and academician or academic faculty conducts these things. That is like sowing the seeds in the brain. But you don't eat the fruits. You don't see this tree. The fruits and tree, and the tree growing from the seed and becoming fruitful, is known when you interact with them outside when they come back. Therefore, even 10% of the students of the 200 assembled here had an ingrained component of one case out of 5 or 10 discussed. That makes all the difference. And you will be again doing it after a decade. Sir, I have gone to a conference here in the NRI College on a critical care conference conducted by my student. Then, fortunate enough, they called me to see a case. And then, the concerned person, sir, I have done this. Then I appreciated him. Very brilliant author. Sir, this is the same faculty component which is discussed about when I am something here. And that came to me because I attended that. We tell here for the students to present or we talk here to discuss. Not that it will have an immediate fruit, but it is the seeds sown down which will become a gigantic component of leaps and bounds to have an academic ingrained seed to flourish forever and to again make some more seeds in that utilized as a faculty members in other colleges. It is not like an examination of university where the results are immediately announced as a first class and second class. Therefore, academic exercises are not vanity of indulgence, not useless in utility, but are long-lasting customary things which make the rewards of all excellent, which you do not measure, which you cannot measure, but the reaping benefits by the students will be measured in an unmeasurable, calculated way. That's why it is an important component of any academic institution is a strong and robust academic activity, for which our institute is greatly attached under the direct leadership of all our Director General and successor principals and present principal Dr.Pinnamaneni as well as Director. And I thank them profusely, and I keep our Director General for his perseverance in this forever at the highest altitude to be practiced and given back by your positive indulgence in this academic activity. That is the only reward which you can pay for your academicians. With that, I am very fortunate to be associated with this exercise for 1.5 decades. Probably mantles will come to replace old water, should go to replace by new water. And I thank all the participants of academicians and faculty for the last 1.5 decades who traveled, unraveled, and committed by themselves. I am very happy to announce certain departments again realigned and recharged, and certain departments are discharged. I hope all the departments should be recharged. Like I do not mention the names of the departments which are recharged and discharged. So you have to put that introspection and make a full-blown recharge of this. And I should have the difficulty in selecting the cases rather than difficulty in searching the cases. Therefore, you should make the academic hand of the institute to have a difficulty. Your case cannot be selected because there are better cases. But not searching, you please give case, you please give case. That should not be. The moment that we reach that level, that it is on par lines, on par with various institutes of the highest category, starting like an Harvard or Maxwell. I am proud to say that of some of these CPCs were discussed in this forum by others. All CPCs are discussed by outside guests, not players. When I inquired them, they are so happy, sir, for the first time you have kindled interest, neurologists, nephrologists, including from that Volunteer Institute and of Delhi as well as AIMS of Mangalagiri as well as Vellore. When I had a discussion sometimes across various conferences when I go there, that thrills me. The seeds are not gone wasted. That is what the strength of an academic activity of an institute, which depends directly proportional to that of indulgence and participation by the respective departments, not the quantum. And lastly, one single appeal to all my young students: never hesitate to question anything in any forum. Don't think that fellow who speaks here is the ultimate, what is called the Pitamaha of the subject. Nothing. You have to learn to question, even the doubt. A cardiologist can question me, a resident. Sir, either really there are 4 chambers or not. The presenter should answer the question without amount of anything. That should be the spirit of positivity of academic environment. I hope that it will reach to that zenith of it. We already reached above certain levels of beyond par the rest of the academic institutes in the state of separated, excluding it. Now, I request our beloved Vice Principal, Dr. Srikanji, to
Respected Director Dr. Nageshwar, Director Dr. C.V. Rao, Principal Dr. M.B. Meshwar, dear colleagues and dear students, good afternoon. I will be announcing the prizes for the academic activities in the year 2025. Category 1.
They are all judging the impartial by different.
All these prizes were judged by impartially by all the faculty that they have attended the CPCs. Category 1. Interesting cases of academic activities. Number of cases presented by the departments under interesting cases of Academy of Medical Sciences. General Medicine first prize 25 cases. I request the head of the department of General Medicine to come over.
I request all the judges who participated, who selected and made this so successful, which we are having today. Please come as and when we have to come, when you are called for. All judges be ready. Thank you.
Second prize, Department of Neurology, Dr. Vansi, 16 cases. Third prize, Department of Cardiology, 8 cases. I request Dr. Sampath Kumar sir to come up.
Our brain and heart are very
I had a hard time to get here. For how many years ago? 40 years ago? You were here for the last 4 years? 11.5 years. We need not come here for a few months. It's an indication to the fact that Pinnamaneni family that is coming from someone.
Individual prizes for best interesting case presentation. First prize, Dr. T. Nagalakshmi from General Medicine. Cash prize of rupees 3,000.
I don't think any college is doing this, right? Right? So keep doing it. Better learn more.
Best interesting case presentation. Second prize, won by 2 people. Dr. J. Karthik, Anesthesia, and Dr. Jyoti Jensen. Cash prize of 2,000 each. Third prize, V. Abhigna, Respiratory Medicine, 1,000 cash prize. V. Abhigna from Respiratory Medicine. Department and faculty participation. Participation prize, radiology and pathology. I request Dr. Chandrasekhar and Dr. Prasad, Dr. Naveen Chandra from pathology.
Anyone from pathology?
Category 2, Continuous Quality Improvement, Individual prizes for best presentation. First prize, Dr. Akila Jansar, 3,000 rupees cash prize. Second prize, Continuous Quality Improvement, Dr. Abhigna, General Medicine. Third prize, continuous quality improvement, Dr. Pravalika, General Medicine. Category 3, Super Specialty Prizes, Individual Prizes for Best Presentation. First prize, Dr. Bhushan Pate, Urology. Anyone from Urology? Second. Urology. Second prize, Dr. Shaurya, Cardiology. Second prize, Dr. Shaurya, Cardiology. CQI, Super Specialty Prize in Special Category. Dr. Vamsi, Cardiology and Dr. Shaurya, Cardiology. Cash prize of 2,000 each.
Distribute half of this side. Ready, sir? Ready, sir? Okay, ready, sir? Okay, ready, sir? Fine, sir. Thank you.
Cases, 150 cases, I think. We published in 5 booklets, as we all know that. So I sent all the 5 booklets to all medical colleges in Andhra Pradesh. Maybe there are about 20, more than 20. I didn't get any response. Sent back by parcel, and then I wrote again letters that hope you received and let me know. Believe it or not, with all the efforts we have made, we wanted them to see, we wanted them to circulate so that they will start again. For all the colleges only, 4 colleges wrote a reply, 2 lines reply. I was disappointed. Hard work is done. They are good cases, and hopefully I thought they will start in their colleges. But I am utter failure. I couldn't do that. But anyhow, people who have done here, who have gone, who are there, when I ever asked them or in having your classes, especially CPC, where you have to think. None of them are doing, at least in Andhra. So I think you are ahead of the game, you are doing well, you know how to do, work hard, pay attention, always be a teacher. The best way of learning is teaching. Remember that. The best way of learning. You teach, remember, you do well. Thank you very much for your cooperation. God bless you. Thank you.
The first case, repaired the rupture post-MI mechanical complication from Department of Cardiology. Second case, subcostal tab block, a winning strategy for feeding gastrostomy anesthesia from Department of Anesthesia. And nodopathy, Department of Neurology. The hidden aftermath of transfusion from Department of General Medicine. So we'll start the first case, repaired the rupture post-MI mechanical complication from Department of Cardiology, presented by Dr. Saurya, Senior Resident, Department of Cardiology. Session will be moderated by Dr. Sampath Kumar.
Today I'm going to present the case that is repaired the rupture, a post-MI mechanical complication. Case, 60-year-old male, diabetic, alcoholic, smoker, came to ER with complaining of retrosternal chest pain since 2 days, associated with shortness of breath. History of present illness, patient was apparently asymptomatic 2 days ago, then suddenly developed retrosternal chest pain radiating to upper back, associated with sweating, palpitation, shortness of breath, increasing on exertion, relieving on taking rest, and episode lasting for 20 to 30 minutes. Not associated with vomiting, abdomen discomfort, no association with food intake. Past history, no history of similar complaints in the past. Personal history, patient consumes mixed diet, normal sleep pattern with normal bowel and bladder habits, and alcoholic and smoker since 15 years. Drug history, patient is diabetic since 6 years and is on medication, glimepiride and metformin combination. General physical examination, patient is conscious, coherent, cooperative with pulse of 100 beats per minute, regular in rhythm, normal volume, or all peripheral pulses felt, with blood pressure 110/90 in both upper limbs and in supine position. Respiratory rate was 24 cycles per minute, abdominothoracic type, with saturation 90% in room air with JVP normal. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. In cardiovascular system examination, inspection, precordium appears normal with apex appears in the left intercostal space at midclavicular line. And in palpation, apex was felt in the left fifth intercostal space midclavicular line with the palpable systolic thrill at the left lower sternal border. In auscultation, S1, S2 were normal with harsh, loud pansystolic murmur, best heard at the lower sternal border with a grade of 4/6, no respiratory variation. ECG at the time of admission showing normal sinus rhythm with 1:1 conduction, showing evolved anterol MI changes in V3 to V4, that is STT changes. With 2D echo, RWM made the LED territory, that is akinetic anterior, androseptal wall, and it was thinned out with a moderate LV dysfunction EF 35% and mid-muscular VSR of 1.2 centimeters with showing left to right shunt and apical VSR of 0.6 centimeters left to right shunt with no MR, AR, mild TRPF, that is RVSP 30 mm of HD with IBC normal and no PE clot. This is the echo showing mid-muscular VSR, and this is the short axis showing the moderate LV dysfunction and akinetic anterior wall, and this is the apical VSR. Just play out chest X-ray.
From the chest radiograph, it is a mid-inspiratory film. Patient is in rotation. Cardiac shadow is within normal limits. Unfolding of aorta seen with widening of the mediastinum. Bilateral lung fields appear clear up to the visualized extent. Bilateral costophrenic angles are free. Both domes of diaphragm are well outlined.
Blood investigations, HB 10.7 grams with WBC counts 15,000. Virals were negative with TROP-T 452, that is positive. With electrolytes normal, HbA1c 8.2 with FBS and PLBS elevated. And blood urea creatinine on day 1, 28 over and 0.8 milligram per deciliter. And on day 3, it was increased to 54 milligram per deciliter and the creatinine increased to 1.2 milligram per deciliter. hospital course, patient was then admitted to cardiac ICU and was put on CPAP support. Patient developed progressive hypotension with BP dropping to 80/60, suggesting evolving cardiogenic shock, for which we have put inotropic support. Injection noradrenaline was started. Subsequently, the patient showed the features of AKI with rising trend of serum creatinine. Given the worsening hemodynamics, urgent definitive treatment was planned. We have put on patient on injection heparin 5000 units QID with injection noradrenaline infusion at 0.5 microgram per kg per minute. Injection Lasix 20 IV TID with tablet Ecosprin 75 OD and ticagrelor 90 BD and atorvastatin 80 OD. This is an angiogram showing the right system normal and the left system showing the mid LED total cutoff. This is the right system which is completely normal, and in this left. After discussion, patient was then shifted for surgery. VSR repair was planned. VSD closure done with the Dacron patch, and the linear repair of the infarcted LV was done with the Teflon felt. ECG on day 3 of post-op, still showing STT changes in the anterior leads, probably because of the LV aneurysm.
This is a frontal chest radiograph. Mid-inspiratory film. Cardiac shadow is enlarged, showing cardiomegaly. Bilateral lung fields appear clear. Bilateral costophrenic angles are free. Both domes of diaphragm are well outlined. Sternotomic sutures noted.
Post-op 2D echo on day 3 showed VSR repair with LV repair, that is RWMA in LED territory with EF35, akinetic mid-basal anterior and anterolateral wall with moderate LV dysfunction. VSR apical was 5 mm with left to right shunt, and IVS mid-muscular septum showed 2 mm and 3 mm shunts to left to right shunt with good RV function, no MR, TR, AR with normal LV filling pattern, and there was a trace PE.
One is the septum ruptures which result in VSD. The papillary muscle rupture causes severe micromegaly, pulmonary MR, and shock. Third one is free wall rupture which results in tamponade and electromechanical surgery. So VSD we see sometimes once in 2 months or 6 weeks like that. And see, VSD, this patient came within second day or third day, and at that time we thought we can close by device closure. But device closure is very tough because that infarcted myocardium is a jelly-like. So if you are crossing the defect, the ampules are very stiff wire that will cut through the muscle and difficult. We said that if minimum 1 week is there, probably we can try that. Because previously I have done some 5 or 6 patients, 3 patients here and 2 patients in the outside private hospitals. So then I was hesitant, I said we will not take it up, we will see. And then we referred to our Srinivas. He has done his job, he has done a wonderful job. Give him an applause. Because in Vijayawada, I don't think any people will take up for VSD closure on the second or third day. The private hospital, they don't do it because risk of surgery, everything is very high. And other hospital like that, even in Hyderabad, the surgeons will be hesitant to do. They also want minimum 5 to 7 days because the edges will become slightly fibrous. Then they can take a bite and suture it. This year, the second or third day, as they are taking the stitch, it will be gone, coming like that. So it's a tough job, and that what happened on weekend, Monday, when I asked them, sir, he has operated. Then I was really, and I immediately rang up to Srinivas. You are very nicely done, congratulations. And really, it's not that, it's a real and heartfelt feeling of telling, he has done a very good job. Srinivas, now we can talk.
I was hoping when you still, the plan of the cath lab and operation In 3 minutes you can transport the patient there to surgical, right? It's 3 minutes. So that is the reason why the huge corridor can go. But so far we haven't taken any patient where they need surgery directly from cath lab to the operation room. Someday you will do it. Okay, I know that.
Cardiology department is well designed because you have a cath lab, ICU, then immediately surgery, the surgery, post-op, everything like that. So if any patient who's doing angiogram or intervention or something is there, you can do and straight away shift the trolley to the surgical thing like that. Really, it is a very well planned department.
Dr. Srinivas, his experience with
myocardial infarction is common problem. Mechanical complications of the myocardial infarction, they are very common, they are treatable. So all depends upon the three people first confronted with the cardiologist. They should be diagnosed early, treated early, and resuscitated early, and then they plan for surgery. This is the rule for the treatment of the mechanical problems of the acute MI patients. But the problem is, if the cardiologist has detected early, the resuscitation done early, and he has to evaluate the echocardiogram and angiogram. The patient should be managed preoperatively by mechanical approach and the mechanical support of the heart. These patients should be treated early, and if the time goes, the heart has a conduit and also heart as a pump, and also in the circulation, the central organ in the circulation, that is the pulmonary vascular bed and the systemic vascular bed. Both are involved. The pulmonary vascular bed goes to the congestion, and the systemic vascular bed into the constriction. Both are negative for the they should be treated before going into this decompensation, the pulmonary congestion and the systemic constriction. So, once this is detected, we have to treat this patient as early as possible. But again, the mechanical complication, the septum rupture, the spectrum. So, it depends upon the amount of coronary insufficiency and the amount of coronary ischemia and the amount of the myocarditis running and also the infarction. So, this should be assessed, then only we will get the proper results. The main reason of failure of these patients is the myocardial septum or the myocardium is very fragile, we don't take any sutures. So, we have to involve the more areas, the normal areas, we have to take the sutures distant from the infarcted area, so that we have to put a big patch, and we have to involve the patch of the septum, and also we have to remodel the ventricle. That is also key for the success of this surgery, because we have a ventricular remodeling, the geometry, you have to preserve the geometry, then only we will get the better results. So, it all depends upon the amount of the myocardial infarction. So, ultimately, we have to sometimes we have to be conservative, so that when we are doing the remodeling, our sutures may again rupture and we will get the recurrent USD, and again lose the patient on the cot. So, using the patient on the table is mainly due to the suture failure. So, for that we have to take the bites away from the normal area. So, in this patient we have almost taken 2 inches away from the infarcted area, and also we have remodeled the apex of the heart. So that this is the main reason is remodeling, and we have excluded the infarcted septum. So exclusion of the infarcted septum so that it won't contribute the stasis of the blood in the vein.
As far as you are concerned, how many of mechanical ruptures of the post-MI you have done in this institute? And also, what is your outcomes?
Totally, we have a good series. In this hospital, only 7 cases. So,
how much?
7 years, and we lost 1 patient. The patient
because I want to assess the quantum of recovery. Because as per your statement, it appears to be much more than what is recorded outside. Because any septal rupture require 50% mortality, out of it 30% on table, 25% outside within. But it appears Lord Srinivas has again imbibed your hands to make the life come back well and outcome clear.
So, again, depends upon the every once used to be done, it should be done up to 2 weeks, 3 weeks. But it is early as possible is done. So, earliness is all depends upon the pediatrics. They have to detect early and also they have to diagnose the spectrum of the problem and also they resuscitate the patient because the kidney and the lungs are the reserve organs. We have to early some ventilators and non-invasive ventilation. But the key role of the third person is the anesthetist. So now I call up the day. They have managed this patient very successfully. And perioperative management of the vascular flow and the on-table giving anesthesia is very, very important, crucial for the success of this.
Comments for him?
Cardiac anesthesia. Few points I would like to mention regarding this patient. Patient was presented to us in a stage of cardiogenic shock. His BP was on the lower side, which was managed with inotropes. We have to improve his cardiac contractility. At the same time, we have to manage his renal perfusion. If we take a patient who is with less renal perfusion for surgery and we put him on cardiopulmonary bypass, the post-operative morbidity and mortality will be very high because there will be a series of systemic metabolic acidosis, that is because of lactic acidosis, because of pure renal perfusion. So we have to improve his blood pressure, we have to monitor his hemodynamic parameters pre-operatively and then take up the case for surgery. So this is pre-operative part. Coming to the induction part, giving anesthesia for a patient in shock is not easy and it is not equal to a normal patient. So meticulous titrated doses of anesthetics combined with invasive monitoring, combined with inotropes and vasodilator, minimal vasodilator support should be given to this patient so that all the hemodynamic parameters have to be managed and they have to be maintained. For example, the heart rate, they should not exceed beyond the limit which will worsen his ischemia. Blood pressure should not fall, which will worsen his renal status as well as cardiac status, as well as his mean perfusion of his brain. So this is coming to the induction part. And bringing him out of the cardiopulmonary bypass is also a risky part because once the surgery is over and once the bleeding starts from cardiopulmonary bypass, bringing the patient out of the bypass is difficult because his myocardial contractility will be very poor. Heart will not receive the blood that is coming from the cardiopulmonary bypass. So we have to meticulously balance the choice of inotropes. Initially we thought of putting him on noradrenaline and adrenaline, but they didn't work. So we have to again put him on milrinone. So we attempted milrinone that induced a good amount of right ventricular contractility that has taken up the blood and there was good adequate output coming up. And again we have to see that the patient will not land up with low cardiac output syndrome immediately after weaning and in the post-operative period. And we have to manage the coagulopathy as well because we have to see there should not be leak from the suture side, there should not be losing of the blood from the operated side. We have to give adequate anticoagulant to combat the heparin which we have given during the cardiopulmonary bypass. Once we bring him out of the operation theatre into the post-operative period, again we have to do series of EVGs, we have to manage his ventilatory weaning and we have to manage his hemodynamic outcome. So all these efforts have brought positive result, though it has taken time and patient have recovered well.
Srinivas said, see, he is a very good surgeon, he does a lot of complex cases like Bentol, all those things. But the only thing our Pinnamaneni is there, we do a lot of good work better than Vijayawada city, but it's not projected. See, I put in our cardiology group, but still the response is very poor, they don't appreciate, they say, well, that. But when they are outside people there, they do a very good job, life-saving job like that. So it's all so much of things is there. So if the projection is there, then more people come. But some of the cardiologists and cardiologists know that what work we are doing, they refer patient, not the other patient, but some of the cardiologists privately practicing, they refer patient mainly for device closures, mitral balloons, and sometimes like these septal ablations or post-MI complications like that. In that way, they encourage, but still our cardiology, in general, our institute is not projected outside like other medical colleges. Like then definitely we'll have more workload and more training and better everything. Thank you all. So the administration has to look into that, whether how to project that. Pinnamaneni is doing a good job. Really major goal. See, not because of money or other things.
Thank you. So the next case, subcostal tab block, a winning strategy for feeding gastrostomy anesthesia from Department of Anesthesiology, presented by Dr. Pankaj, Junior Resident, Department of Anesthesia. Moderator, Dr. Govardhani, Professor, Department of Anesthesia, Dr. Ladari, Assistant Professor, Department of Anesthesia.
Good afternoon, everyone. Today, I am presenting a case of left subcostal tab block along with rectal sheath block, the winning strategy for feeding gastrostomy. Case 1. A 85-year-old man, resident of Nandigama, came to hospital with hoarseness of voice from 4 months, difficulty in swallowing solids from 3 months, and difficulty in swallowing liquids from 10 days, and cough with expectoration from 3 weeks.
These are plain and contrast images of axial sections of CT neck. There is an evidence of large, irregular, exophytic soft tissue installation noted in the region of hypopharynx. It is displacing the vocal cords towards the center, and also here it is infiltrating the adjacent structures. Here it is mainly centered in the left side, but it is crossing the midline and extending to the right side also. Here it is completely obliterating the pyriform sinus and it is extending inferiorly. Next image. Here it is reaching the posterior pharyngeal wall also, and it's also infiltrating the left lobe of thyroid. On post-contrast study, it's showing heterogeneous enhancement. The areas of non-enhanced areas represents necrotic components. As there is infiltration of adjacent structures and loss of fat plates, this could represent any carcinoma of hypopharyngeal carcinoma.
The indirect laryngoscopy finding shows there is no movement of left arytenoid, pooling of saliva in the left pyriform fossa, left side vocal cord is not moving with respiration and phonation. Investigations are within the normal limits. And in summary, this is a case of query hypopharyngeal carcinoma with left vocal cord palsy posted for feeding gastrostomy. ASA grade 4 and airway is Malampati class 3 with limited neck extension. And case 2, a 61-year-old man, resident of Vijayawada, known case of right-sided malignant otitis media with skull-based osteomyelitis, had difficulty in swallowing and was on nasogastric tube feeds from 10 months. And he is a known case of type 2 diabetes mellitus from 10 years on treatment tablet glyphosate 50 mg and metformin 500 mg BD, and he is a known case of hypertension from 1 year and on treatment tablet significant 10 mg BD. The MRI brain scan was done outside and we don't have the fillings of the scan. And the report of MRI brain scan shows soft tissue thickening seen involving the prevertebral space extending into the retropharyngeal, parapharyngeal, and bilateral masticator space, and there is extension posteriorly involving the basisphenoid and basiocciput of the base of skull involving jugular foramina and hypoglossal canal on both sides, predominantly on the right side with suspicious involvement of 9, 10, 11, and 12 cranial nerves. On CT section, ipsilateral prominent pyriform fossa with paramedian localization of right vocal cord which caused right vocal cord palsy. Investigations. Hemoglobin is 8 grams percentage, fasting blood sugars is 177 milligram per deciliter, and blood urea is 55 milligram per deciliter. In summary, this is a case of skull-based osteomyelitis secondary to right malignant otitis externa with right vocal cord palsy posted for feeding gastrostomy. ASA grade 4 and airway is Mallampati class 3. Anesthetic concern. Anticipated difficult airway with distorted upper airway anatomy, high risk of aspiration due to vocal cord palsy, increased risk of airway collapse and aspiration after induction or sedation. Patients are malnourished with reduced physiological reserves, and choice of anesthesia directly impacts the airway safety and outcome. Anesthetic techniques for feeding gastrostomy. Local anesthesia, regional blocks, central neuraxial blockade like spinal anesthesia and epidural anesthesia, and general anesthesia. In this case, we have selected regional blocks and we have given bilateral rectus sheath block along with left subcostal tab block. Why we have preferred regional blocks? Avoidance of general anesthesia in a patient with anticipated difficult airway, reduced risk of aspiration in the presence of vocal cord palsy, excellent intraoperative and postoperative analgesia, hemodynamic stability and reduced opioid requirement. Early recovery with preserved respiratory function, and difficult airway cart was kept ready and ENT surgeon was on standby for emergency tracheostomy. Left subcostal tab block. Nerves blocked the anterior rami of thorax nerves from T6 to T9. The ventral rami of the intercostal nerve travel between the internal oblique muscle and the transverse abdominis muscle at the mid-axillary line. It gives lateral cutaneous branch of intercostal nerves and it travels and continues up to the rectus sheath and it gives anterior cutaneous branches at the rectus sheath. Area of analgesia is upper abdominal wall and drug and volume is 20 ml of 0.25% bupropion. Technique. A linear probe is used. A position is parallel to the costal margin or just below it. The local anesthetic is deposited in facial plane between the rectus abdominis muscle and the transverse abdominis muscle along the costal margin. The rectus sheath block. Nerves blocked are anterior cutaneous branches of T7 to T12 intercostal nerves. Area of analgesia is midline and paramedian paramedian midline of anterior abdominal wall. Drug and volume 10 ml of 0.25% bupropion on each side is given. Technique. A linear probe is used and position is transversely just lateral to the midline between the xiphisternum and the umbilicus. Local anesthetic is injected into the facial plane between the rectus abdominis muscle and the rectus abdominis muscle on the posterior rectus sheath. In this video, you can see the rectus abdominis muscle and the posterior rectus sheath. We have placed the tip of the needle between the rectus abdominis muscle and the posterior rectus sheath, and when we have given the local anesthetic and the rectus abdominis muscle is separated from the posterior rectus sheath. Intraoperatively, the patient received 3 liters per minute of oxygen via nasal cannula and was monitored for vital signs. This block provides somatic analgesia only and no visual blockade. So we have supplemented injection fentanyl 1 microgram per kg and VAS score was 0. VAS score was 0 intraoperatively and postoperatively. Conclusion. Regional anesthesia with abdominal wall block is safe, justified anesthetic technique for feeding gastrostomy in patients with anticipated difficult airway and high aspiration risk and poor physiological resources. On this day, we pay tribute to Dr. Seshagiri Rao Mallampati, MD, who has done his MBPS from AMC and died on 9 February 2026.
Tell something about Mallampati. What he found, invented, or what he
Pre-anesthetically, anticipation of difficult airway.
Mallampati score meant for what?
For anticipation of difficult airway, without any scans and behavioral discussion.
Now the case is open for remarks and commentary from the faculty, anesthesia, and government. Because we are all trained now than the conventional anesthesia in this particular era of 21st century, where the old days of aging population makes anesthetic challenges much more complex, particularly the malignant comment.
Many patients coming from feeding gastrostomy, they are very malnourished and they have very less physiological reserve both in cardiac and
therefore quality of life of breathing will be preserved.
Yes.
This might be granted.
For these cases, people are general, they will be hemodynamically compromised even at the injection time. And not only that, any mass in the hypopharynx or the airway, then we have a difficulty in securing the airway, and at the time we may ensure they not intubate or cannot oxygenate also in such cases. So regional blocks have been
less technically very difficult and less cumbersome and less
requires an expertise.
The most rewarding. Wonderful. Had you an experience of not doing regional anesthesia in your expertise in the last, with reference to the gastrotomy, what is it? Probably you may add on. What could have been done in the last century for gastrotomy? And I will ask our sentence.
Usually these gastrostomies are done under the local anesthesia, but there will be a sparing.
They are used to do it only cutaneous and nerve or anything. Probably the way in which the nerve goes is usually to be blocked rather than knowingly. It is a blind procedure. And we will give a stab like this if our surgeons know it. Left hypochondrial stab with a little amount of it and then put a malgrats at that time, not otherwise. Then we make it replace with some other tube and tie the knot here and keep it up and goes. Now everything is defined. That is technology coming in. Very precise. Labor. We can identify the nerves also if you are very good at anatomy. Anything further ultimately? Don't leave for nutrition of all the end-stage diseases of neurology, benign neurology like cerebral palsy, or a malignant neurology of beard, or supramalignant oncology of something else. You can still enjoy the feeling to have a beautiful smile before death and along with it. Thank you. You must train all of the young fellows because they are the to treat the pediatric population of the aging society.
In class 2, we can only see partial body of the uvula and we can't see the tip of the uvula. And hard palate, soft palate, and the tonsillar pilus are visible. In class 3, we can only see the base of the uvula and the hard palate and soft palate. In fourth class, we can only see the hard palate and the soft palate. And grade 5. In grade 5.
Wonderful clinical observation of all excellence and brilliance. And but for his birth in India, you would have got Nobel Prize from that. That is the only repentable thing.
Take the papers from Alfred Nobel. That's how he established Nobel to be known as this. I went to his, well, he lived in his house. So that's what. Such things history must know. It's very.
They wanted to find a drug for the coronary vasodilatation like that. Finally, nitropism are there. When they are doing research, they come with nitrotoluene. Say it's a container of nitroglycerin or the nitro compound. And to the surprise, they found that it's a highly inflammable substance. And then all this dynamite, everything was started. And then they realized that it's a very invention which is going to spoil the entire world like that. So that's why install all the effects into the mobile device. So finding out drug for cardiac, they got into the.
We'll go ahead with the next case. Nodopathy from Department of Neurology, presented by Dr. G. Raju, Junior Resident General Medicine. The session will be moderated by Vamsi Krishna sir, Department of Neurology.
Good afternoon. I'm Raju from Medicine Department, presenting an interesting case of nodopathy from the Department of Neurology. The 41-year-old man brought to hospital with complaints of paresthesias of distal extremities since 3 months, swaying while walking since 10 days. Patient was apparently normal 3 months back, and presenting complaint started as tingling and pricking sensation in both lower limbs since 3 months. Incidence in onset gradually progressive, distant of proximity. No associated back pain, no associated urinary tension or incontinence. Swaying while walking since 10 days. Incidence is onset gradually progressive to the point where the patient has frequent falls. No complaint of headache, nausea, vomiting. No complaint of loss of consciousness, walking around more, upper lung of eyes, involuntary movements, involuntary defecation and depression. No complaint of SOB, chest pain, abdomen, loose stools, and no complaint of decreased urine. Past history, patient came with complaints of similar complaints 7 years back and was given IV steroids treatment, injection IV pulse steroid treatment, injection methylprednisolone 5 mg for 5 days, for which he responded and well and discharged. History of old right Bell's palsy present. Not a known case of diabetic hypertension hypertension. Personal history, patient is alcoholic since 15 years, stopped 3 years back. Known case of bronchial asthma since 15 years on meteorological inhaler for about 200 mcg SOS. Non-smoker, patient has normal sleep and appetite. Patient takes mixed diet, normal bowel and bladder movements. No food, drug and environmental allergies. Family history, no history of similar illness in first degree and second degree relatives. No history of consanguinity present. General examination, patient is conscious, coherent, well-oriented, time-based person, moderately built and nourished. BMI is 28. Cases is E4, V5 MCs, no pallor, no excess, no sinuses, no clubbing, no lymphadenopathy, no pediatric. Vital set presentation, blood pressure was 130 by 80 mmHg, pulse rate is 98 beats per minute, respiratory rate is 20 cycles per minute, temperature ephemeral, saturation 99% at the room. Systemic examination, cardiovascular examination is normal, no harmless gut, respiratory examination, bilateral normal vascular response present, GIT soft and bowel sounds present. CNS examination, patient anamnesis score was 30 by 30. Slurred speech was present at the time of examination. Cranial examination, first and second nerve examination is normal. 3, 4, 6 nerves are normal. Fifth nerve examination is normal. Seventh nerve, right element facial weakness was present. 8, 9, 10, 11 nerve examination is normal. 12th examination nerve is normal. Motor system examination, attitude of the limbs is normal. Bilaterally symmetrical bulk is present. Tone bilaterally symmetrical. The power of both upper limbs and lower limbs were reduced, which was 4 by 5. Reflexes, both plantar reflexes were mute. Deep reflexes, only triceps was receded. Sensory examination.
All other deep reflexes are lost.
All other
0. Only tricep 1 plus.
Sensory examination, patient has decreased sensation from lower limbs up to L1 and T5 to C8 limbs. Cerebral examination, past pointing was present, but with swaying while walking, wide basic gait was present. In this video, we can see the patient is finding difficult to get up from sitting position, which suggests of weakness, and patient is attacking. No meningeal signs are present, no spinal and cranial effects are present. Critical diagnosis, peripheral neuropathy with cerebral ataxia for evaluation. ECG is toilet stand ECG showing the normal sinus rhythm. Chest X-ray.
This is a frontal chest radiograph showing trachea in midline. Cardiac shadow is within normal limits. Bilateral lung fields appear clear. Mild elevation of right dome of diaphragm.
ANA profile was negative, VDRL was negative, between beta is a normal lipid, virus was negative. LFT shows mild transaminitis and CV shows proteinuria traces. 2-day shows mild constant curvature with no renewal motion abnormality with EF of 60%. MRI.
This is an axial flare MR image of brain. Here we can see mild volume loss noted evident by prominent sulci and cisternular spaces. Here the ventricular system appears normal. There is evidence of mild periventricular flare hyperintensity is noted, suggestive of mild small vessel disease. Rest of the brain appears normal. There are no any collections or any mass lesions. This is a DWA axial MR image. There is no restriction noted in this image. Rest of the brain grossly appears normal. Next image. This is the T2-weighted sagittal MR image of whole spine screening image. Here the curvature appears normal of cervical spine, dorsal spine and lumbar spine. Vertebral bodies are showing normal signal intensities.
Orbital cerebellum is normal or abnormal?
There is atrophy.
Atrophy or normal? Atrophy is there. Because in our history there is
this gate is there. Vertebral bodies.
Atrophy at the age of 40 years. Can you?
Vertebral bodies.
Sequence of the cerebellum to know what is the chorea levels and how many are nominated to say cerebellar or bilateral asymmetrical and all. Unless important, it would have done minute loss of volume of cerebellum disproportionate to the age is always a secondary here that is outcome.
This patient has presentation of both peripheral and cerebellar in one. Initially, there is difficulty in diagnosis because
I will put a perception. Easy becomes symptomatic and then you found out cerebellar signs after the presentation. Before that, why I'm asking is a subclinical cerebellar deficiency will be made overt by the loss of inputs of
the same thing happens because he's having the same like a cerebellar symptoms since long time.
But yeah.
2 years back also he's having a cerebellar atrophy. Now these symptoms got aggravated because of the
yes. Because they are complicated with
large fiber involvement.
Unicerebellar dysfunction becomes over by loss of vision and loss of reception becomes possible. That's it. Now you have to explain on condition and then you have to answer certain of the things as a resident of medical neurology.
This is a screening MR sagittal section of intervertebral discs also appear normal except for L5S1 disc and C4 C5 disc showing mild disc bulge ending on antithecal side. Posterior elements also appear normal to the visualized extent and curvature of the spine appears normal.
So the evidence of sensory motor axonal neuropathy. So systemic differential workup was done for cerebellar involvement with peripheral neuropathy. Hereditary ataxia. The supporting factors here are cerebellar ataxia with peripheral neuropathy. The points going against her, no family history, late onset, no long-standing progressive growth. Custom disease. The point going against her, no ichthyosis, no retinitis pigmentosa. No fat malabsorption, no acanthosis, no childhood onset, where the points against is A-beta lipoproteinemia. Alpha-related neuropathy. In previous admission, patient was responded to IV methylprednisolone. Paraneoplastic neuropathy.
When one cerebellar ataxia is symptomatically manifested, you can't go back to relapse. It is progressive. The very fact that ataxia is relapsing and remitting, it should be not a primary cerebellar total deficiency. Compensated cerebellum and which decompensation occurred tell us the risk.
Paraneoplastic neuropathy. There is no evidence of malignancy as evidence in CT chest and CT abdomen.
These are axial and coronal images of CT chest. There is no evidence of airspace consolidation or bronchitis except in fibrotic strands. The rest of the lung pits appear clear. No evidence of any effusion or any nodules or any mass lesions. Next image. This is a coronal image of CT abdomen. Here the liver, spleen, both the kidneys are showing normal size, shape and attenuation. No evidence of any mass lesions noted within these organs.
Multisystem atrophy, the points going against are no prominent autonomic failure. Peripheral neuropathy is not typical in multisystem atrophy. Toxic or metabolic causes, vitamin B12 and B1 are within normal limits. No heavy metal exposure, no hypothyroidism. Miller-Rogers syndrome, no ophthalmoplegia present. No typical acute monophasic pattern is present in this case. Infectious, the neurosyphilis and Lyme disease serology was negative and no systemic features were present. Fundus examination was completely normal at the time of examination. Mitochondrial disorders were eliminated. There's no stroke-like episodes, no myoclonus, no macular recurrence history. CIDP, prominent tremor is atypical in this case, but the possible final diagnosis could be CIDP and alcohol-related neuropathy and cerebral environment. Treatment given was we have given pulse steroid therapy again. IV methotrexate 5 mg, IV 24 hours for 5 days with multivitamin support. Despite giving IV steroid this time, patient weakness didn't improve and we worked out for other chronic immune neuropathies. We suspected autoimmune neuropathy based on the symptoms such as areflexia, ataxia plus tremor and poor steroid response. We sent the sample to Amrita Institute of Medical Sciences in Kerala, in which contacting 1 and sulfate antibodies turned out to be positive. Despite giving IV steroid this time, patient weakness didn't improve and CIDP autoimmune panel was sent, which showed positive for contacting 1 sulfate antibodies. Patient was advised immunotherapy, rituximab. As he is not affordable here, patient was referred to Guntur JGH, where he received 2 doses of rituximab of 500 mg. After this, patient was walking without attacks.
Followed post Guntur.
Yes, sir.
Now comments from the wonderful case. Why I am saying before our professor of neurology talks something, it has come into our understanding, not existence. It is there, but we missed it for last 1 century, and it came in the last 1 decade as a different part from the autoimmune spectral disease of autoimmune diseases, Guillain-Barré, and then other spectrum of medicine and so on and so forth, then Mogart. Now it is something new. That we like to talk. By the way, before that, what is the role of Nodal Ranivay? It is not Helmut or Jarasati or Parker and this, not the straight of all miles. Node of Ranivay. We are presenting the brilliant case of rarity. Probably, even if you become a neurologist, you may not see it again. President, what is the role of Ranivay? What is its physiological importance? You must talk. Lord of Ranivay, that made us to have our telephones from after Relling got. When Graham Bell invented the telephone and he wanted to convey the message to transatlantic from Britain to some part of USA. He failed many number of times because the conducting pathway is there, but there is a lateral dispersion of the entire component of signal. Even if he has made a signal like Kumkata's road, it is submerged in the transatlantic at the golden triangle that various times never gone into. Then, when he has some discussion with the pathological neurological specialists, how the brain and how the peripheral nervous system conducts the electrical impulse from this side to a 6 feet or 5 feet or 4 feet length of land without losing the action potential capabilities. That is great. Sorry, I am talking before. That how it got made is it interrupted the content and excited the things. That is called amplification by the load of granular.
Even
the jumping
energy is conserved because we conserve less energy.
And then added on. This is a continuous circuit of electrical potential. Jump, add, and potential. That is done by the load of granular. If you recollect in physiology, the axon is surrounded by myelin, interrupted myelin component, going myelin. That is what is called load of granular. It is amenable and can be attacked by your immune system. Axon containing myelin is not in a position to be attacked by your immune system. A load of granular, that point is exposed component to back cells, which will be struck by the immune cells.
So previously, like it's in when you were student, when we used to treat like this CADP or GPS presentation. But nowadays, whenever the patient presenting like GPS or CADP like features who are not responding to treatment, you should consider neuropathy or paraneuropathies. And if patient of GPS or CADP like presenting like typical features like sensory ataxia, tremor, like granular involvement, atomic feature, respiratory involvement, particularly who is not responding to treatment. Like in conventional like steroids or IVA in case of GB syndrome, you should always think of neuropathy. Previously, like patient not responding to IVIG plasma, there is no treatment available. But nowadays, when we are sending panels for this neuropathy, it is positive. We should treat with rituximab. Patient will improve. Rituximab 25,000.
That's cost is
I think 12,000.
All are 5 figures only.
And to 12,000.
No.
Sorry, in this patient is a non-alcoholic. Sorry, even in literature is showing that even in neuropathies they can have a simple drug. Literature.
Wonderful component. Why should you know this? Because there is a good treatment.
Yes. Sir, previous GB syndrome, patient not responding to IVIG or plasmapheresis, then we left as it's a severe form of GB. But if we send this antibody, this subgroups.
Because
nowadays it is thought to be that is a neuropathy or paraneuropathy.
At this juncture, I will make a little comment. In the same way, all autoimmune diseases, NSLE, take one basket. In the same way, RA was group rheumatoid arthritis group feedback. The moment we are starting the treatments of various biological, we come to understand that there is variation. And one of your student, juvenile rheumatoid arthritis entity is there. But nowadays, juvenile arthritis is not rheumatoid at all because it is never has rheumatoid problem. Why? The immunology is different. In the same way, RA, 0 negative RA, 0. There is no understanding more and more of immunology. More specific antigen-related antibody injury are defined by the parents. That's what. In the same way, the bag of your AIDP is now becoming a basket of big basket of conundrums, where in which the drum can be backed for an outcome and drum will be silent for no outcome.
Even some variants of this, sir, the response rate is nearly like 90 to 95% response.
And reversibility, totally. That's what తెలిసిందే మొన్నండి because of ignorance we group many things, but later our ignorance is shattered, then we will make it little cloudy components.
Sir, in not the cause, sir, previously there is no such like an antibody testing for this thing. Nowadays they started testing like the patient not responding to conventional treatment. They started testing these antibodies can
get it. Sir, rituximab is costly because why the biologicals are costly or the manufacturing component is very complex. Even if it becomes after 10 years, the cost has to be there because for a biological laboratory to establish, we need about roughly 250 to 400 crores even for insulin molecule. That's why they can't be reduced even after the patent period is over. But now, You got a lot of competition control. Reduced mark 1 second and plan is very good. Now it is coming for a 4 figure and 3 figure. A wonderful case, but you have not done your homework to the fullest potential. Contacting one antibody. Now I will put the questions on all the residents. You must understand the antigenic nature of myelin by knowing the antibodies. This contacting will never occur with reference to AADP, where in which they are related to 6 group of myelin related antibodies, antigens. This is a little different. Therefore, all the postgraduates should know the structural antigens of a normal myelin. Probably by the time you become professor, there will be hundreds of antibodies of specific nature and a specific biological theory. Then you don't say AADP. Not these fellows are talking about AADP without any knowledge, and you can gloss upon answer after 25 years. Now, I congratulate all the winners. I congratulate the heads of the departments of winners, and I